Okay, we are here today to celebrate Juneteenth. I want to say happy Juneteenth to everyone. And for those of you who don't know me, my name is Dr. Sharon Malone. I am an OBGYN and the Chief Medical Officer of Alloy Women's Health. And Alloy, if for those of you who also are not familiar, Alloy is an online telehealth company that provides education and access to menopause-trained doctors and hormone replacement and other medications delivered directly to your door. Now, I am joined today by my dear friend, Dr. Jayne Morgan. Dr. Morgan is a cardiologist, and she is also the community education. She's the executive director of health and community education at Piedmont Hospital in Atlanta. She is also the creator of Stairwell Chronicles. And this is a little tidbit that many of you may not know, but Jayne is also the mother of CNN correspondent Omar Jimenez. And if you've not seen him, I promise you, you will. And that is really where I'd have to say Omar gets his screen cred from, because Jayne is also, for those of you in the Atlanta area, you may have seen her on multiple TV appearances talking about COVID and as well as other health issues. Now, I know that many of you have questions today, and we are here to talk about the menopause disparities as it relates to African-American women, and what a befitting topic for Juneteenth. Now, for those of you who may not be familiar, I just want to give you a little bit of a rundown of what we are talking about today and how this differs for women of color. Now, the average age for menopause, and when I say menopause, I mean having had your last period, and that's confirmed a year later. So we know for sure you've had the last one. The average age for that is about 51 and a half. For African-American women, menopause tends to start earlier, almost a full year earlier than for white and the general population. African-American women also have more symptoms. The symptoms are more severe and last longer. And that transition, which is the period of time between when your periods have started to change, and this is also called perimenopause, this can go on for as long as 10 years. So the traditional symptoms that we talk about, hot flashes, mood swings, sleeplessness, and the other 30+ symptoms of menopause, just know that with studies that would have been following women longitudinally, we have found that this hits really differently for Black women. Now, in addition to that, and I think what is more disturbing is that even though Black women are often more symptomatic, they are least likely to complain of these symptoms to their doctor. And when they do complain to their doctor, they are only half as likely to get a prescription and get relief for their menopausal symptoms. And I want this conversation to really focus on menopause and also some of the longer term health implications of what happens at menopause. And that's why it's so important we have Dr. Jayne Morgan here, who is a cardiologist. And what I'd really like to set up for you is the fact that menopause is also a time when your cardiovascular risk goes up. Prior to menopause, women have about half the risk of heart disease that men do. But then something happens at menopause. And I'd like to ask Dr. Morgan to please explain to our viewers, what are those risk factors and what happens to women at menopause?
Thanks so much, Sharon, for having me today. And this is such a sage and timely conversation, not just for Juneteenth, but for us to understand really what is the interaction of our hormones and our heart, because we don't often think about them, and not just that connection for Black women and Black America, but really for all women. What is this connection? We certainly suffer more, but we need to understand what these hormones mean. When we look at the heart and we look at the progression of heart disease, we are beginning to understand that a lot of that has to do with inflammation. And you may or may not have heard about that. So inflammatory processes that occur inside of your arteries. We now are beginning to understand that estrogen actually has anti-inflammatory properties. And so what happens during menopause is your estrogen levels begin to decrease and continue to drop and drop and drop. That is why your risk of a heart attack or some type of heart event tends to equal that of men on the other side of menopause than prior to menopause when your risk was a lot lower. That's why Sharon and I thought it would be great if the two of us got together to really have this discussion of what is the significance of this transition in a woman's life and what we need to do to empower ourselves to make certain that we can understand and advocate. Because as Sharon well knows, many physicians are also not familiar with this transition in a woman's life. And in fact, when we looked at a recent survey, only 26% of primary care physicians were comfortable managing a woman's heart symptoms. And if you can believe this, only 42% of cardiologists were comfortable managing a woman's heart symptoms, mostly because if you think about it practically, most cardiologists are men. And we still in this society and within our culture have a very high tolerance for the suffering of women and the suffering of minority populations. Our tolerance for that is high. And so your symptoms are more likely to be minimized or attributed to other things.
Right. And I think that is a big misconception that people have to be aware of, because I don't think that even the general population, women don't realize how much at risk they are for cardiovascular disease after menopause.
Mhm.
There are a couple of other things that happen to you at menopause that increase your risk. One of them is type 2 diabetes. And type 2 diabetes tends to go hand in hand with weight gain. Now, the one thing that happens to you at menopause is not just that estrogen affects your weight positively or negatively, but what estrogen does do is that it matters where that weight goes when you gain it. Because for women who are gaining weight after menopause, their weight tends to go more to the midsection, which is called visceral fat. It creates visceral fat, which means, and all the visceral fat is just you have fat. Not all everybody sees the roll that's around your waistline, but you don't understand that that roll that is around your waistline is also happening inside around your internal organs, particularly around your heart. And as Jayne mentioned, that issue of inflammation also happens there and increases your risk for heart disease. Another thing that happens for women, and it starts in the perimenopause and continues through menopause, is hot flashes. Now, we tend to laugh. Everybody thinks hot flashes are funny and, go get a fan and, stick your head in the freezer. It's not there. These are not benign things. The other thing that we have found with what's called the SWAN study, which is the study of women across the nation in menopause, we found that women who have more severe hot flashes, that is also an independent risk factor for cardiovascular disease. Now, that is something that I think if more internists, more primary care doctors, and even OBGYNs understood that link between hot flashes and developing heart disease, they might be a little bit more, they might be treat those hot flashes, because it's not something that's going to last for 6 months and go away. As I said, these symptoms may go on for years. The other thing that is a risk factor for heart disease that happens at menopause is this increase in the risk of type 2 diabetes. And Jayne, can you talk to us a little bit and tell us why is it that type 2 diabetes increases your risk for heart disease?
When we look at type 2 diabetes, so diabetes is not all equal. There's type 1 and type 2. Type 2 is the type that is associated more so with obesity and advancing age. Type 1 is the type, this is generally speaking at a very high level, that is insulin dependent. And you often can see that in children. So when we look at type 2 diabetes, which is generally the one with which we are familiar, what you see is this insulin resistance. So you have enough insulin, but it's not really able to penetrate these cells of your pancreas such that you can utilize your glucose, those sugars, appropriately. And so what happens? Sugar levels are increasing. You begin to gain weight. You can develop this visceral fat, right? So you have fat around your middle, which, as Sharon has already said, it means that you really are having fat deposits around the organs inside of your body. But it also can increase your lipid levels, your cholesterol levels. And then what else? You have this inflammatory process. So you see how this entire cascade feeds upon itself. And what does it all mean? And how do we need to begin to understand how we can begin to retard that process? And what options do we have to not only feel better, but to be better, to not only feel healthier, but to actually be healthier? And this is where we need to have this conversation. My background is very strongly in clinical trials. When we look at women in the menopausal stage of life, we see a dearth of participation in clinical trials, but also a dearth of research that is focused on this particular demographic. So this is called a vulnerable population. You may not think about that, but this is actually a vulnerable, underrepresented population. We do not have enough consistent randomized clinical trials in this particular population to really guide evidence-based medicine for how we need to move forward. And that's what your doctors are looking at when you come in.
Right. And that's a very important point, Jane, because unfortunately, as we look at the amount of money that's spent, from our NIH budget, research budget, and how much of that goes to issues that are particularly health issues related to women, it's a mere fraction of their total $45 billion budget. And when you really get down to how much of that is really dedicated to women of color, then it's a fraction of a fraction. And this is something that has really got to change. And an interesting point, I was talking to a friend of mine, I don't know if you know her, Jane, Dr. Linda Goler Blunt. She runs the Black Women's Health Initiative. And one of the things that she said is that, we have really got to, we've got to increase the number of doctors, the number of researchers that are interested in this as field of study. But she said the reality is that even if you doubled or tripled the number of Black doctors or doctors and women of color who are actually in this field, first off, it's going to take a long time to get these people through that pipeline. But even with that, there is still an underserved community by underserved physicians. Only still, since I think for the last 50 years, isn't it true, Jane, that the number of African-American doctors is like 5%, and we've been stuck at 5%. So, the notion that someone is coming to save you in the short term is really not going to happen. So what we've got to do is figure out how to create a groundswell and how to advocate and how to make sure that our health needs are being met. One thing that she said that just struck me, and I was like, you know what, you're absolutely right. She said they had done a survey of African-American women, and when they asked, what is the reason why more Black women don't participate in studies? And it wasn't for the answer that most people think. It wasn't because of Tuskegee experiment or somebody's afraid of Henry, so what's going to happen to you, what happened to Henrietta Lacks. The number one reason why Black people don't participate in studies is because they are not asked.
That's right.
Just simply not asked. And there are not enough trials to enroll them in. And that, I think, is the fundamental change that we've really got to work on.
Right. Just to add to that, when we look at the population here in the United States, 80% of African Americans are seen by African American physicians. And yet 98% of clinical trials are led by white males. So you've got 80% of the population, when we talk about being approached, the number one reason that any person of any race, color, creed, religion, background enrolls in a clinical trial is that you are approached by a trusted physician, a trusted source. So if your trusted source, 80% of the population, is not even connected to research or clinical trials or a major medical center, then you can understand where that chasm also comes in and where we have to do this education to make certain that we understand the importance of participation and that FDA approved compounds, drugs, and devices are relevant for everyone and not relevant for a slice of the demographic, not just here in the United States, but worldwide. The majority of population in the world is not a white population. And so we need to understand the global significance of approving these therapeutics, and they go out to a worldwide community in which we live, and they may or may not have relevance to all of us.
Yes. Another point I'd really like to make about women of color and menopause is that we don't really recognize the symptoms of menopause necessarily as such. And even when we do, we don't seek help. And I think that this is really, really, really important. I say this all the time, is that we have got to stop normalizing suffering.
Mhm.
Because we have gotten into this mindset where we think that suffering is just part of growing old. We even have incorporated that suffering language into, the lexicon. We say, oh, she suffers from cramps, she suffers from migraine, she suffers from endometriosis, fibroids, you name it. And, we have got to break that mindset that says that that's okay. It's not. And I think that Black women have really got to understand you need to advocate for yourself. This is particularly important at menopause because, as I said, these things are not just bothersome. These are things that the symptoms that you have in menopause, and we talked about the hot flash and the increased risk of cardiovascular disease. Another independent risk for cardiovascular disease is disturbed sleep. And it's the same sort of issue that we have where women don't complain of it. There have been studies that said that for African American women who have the most disturbed sleep of any demographic studied, they subjectively don't even report it. You can go do a sleep study. They know how many times you woke up in the middle of the night and how long it took you to go to sleep. And we have just incorporated that as, well, that's normal. It's part of going old. And we have to say, look, these things are all interrelated. When we talk about stress, we talk about sleep, we talk about mood swings and brain fog. Now, bear in mind, they're all are tied together. If you don't get a good night's sleep, and Jayne and I know this better than anyone, I know from back in the days when we used to be residents, I'm not as nice or, as crisp the day after a night on call and having been up or being interrupted several times throughout the night. And that's when you're young and you can take it. So imagine that kind of interrupted sleep and what that does to your cognitive ability the next day and your mood and your ability to just how you feel. And we have got to understand that treating things like the symptoms of menopause, those hot flashes, those night sweats, that sleep disturbance is vitally important because we're not only just making you feel better, and there's nothing wrong with that, by the way. We always kind of downplay that as if just making you feel better is not reason enough to treat it. It is, but there are also those longer term health implications that I want women to be aware of.
Absolutely. I mean, we're drawing an absolute hard line between menopause and cardiovascular outcomes. This is not a dotted line. And not only, as Sharon says, do we minimize our symptoms at menopause, we then, with an increased risk of cardiovascular disease, since our menopause symptoms have been minimized, now we have an increased risk of heart disease. We minimize our heart symptoms as well. The
Yes.
symptoms of a woman may be different from a man. And what do we say? If sometimes you may not have this crushing chest pain, shortness of breath, you collapse in the street, this big dramatic event where everyone comes and rushes to save you. You may have something, you may just be chronically tired. You may have chronic back pain, or you might have jaw pain that might take you to the dentist. You may feel run down or as if you have the flu, when in fact, you actually could be suffering a heart attack. And it's the reason why women postmenopausal, their first incident of a heart attack that takes them to the hospital is oftentimes fatal as opposed to a man. It's not because your heart attack is larger, it's because it's gone on for such a long period of time while you have minimized those symptoms. And here's the scary part, your doctor may have minimized them as well.
Yes.
That's where we get back to that. So we've got to be able to step up and advocate. And Sharon and I are drawing a direct line between menopause and heart disease. You have to look at the two of these going hand in hand. And what is our tolerance for suffering in our culture for women and for populations of color? We must not normalize that.
Right. And you made a very good point, Jane, is that again, even when women complain, they go to their doctors with these symptoms,
Mhm.
they are more than likely not going to get these symptoms addressed. And I think the number is something, and you would know better than I, Jane, but there's something like 50% of,
Mhm.
of women who come in and they get an EKG, they have evidence of a prior heart attack that they didn't even know they had.
That's right. That's right. For all of those reasons that I stated, not only do we minimize our symptoms, your doctors will also minimize our symptoms. That's where I get back to there's not even a large percentage of physicians that feel comfortable managing a woman when she comes in really with cardiac symptoms that are considered atypical. And we've got to get away from saying a woman's symptoms are atypical. Maybe it's the man's symptoms that are atypical. Maybe we're
Right.
actually having the normal symptoms. And we need to make certain that we learn what the normal symptoms are first and then extrapolate it to the atypical. So
That
who's
is
to say which is who's having the normal symptoms or not?
That is exactly right. We are using the standard of men to
That's
sort
right.
of dictate how we are seen. And we're 51% of the population. So,
Mhm.
okay, we got to leave that behind.
Mhm.
I think that one of the other things, and I want to hit on this just briefly because we certainly don't have time to go in this, but here's another link that I want women to sort of make is that when we talk about just briefly about Alzheimer's,
Mhm.
and the reason why you need to know what the cardiovascular risk factors are is because the same risk factors for cardiovascular disease are the risk factors for developing Alzheimer's.
Mhm.
And they sort of go hand in hand. You start to see, this happen in women who are postmenopausal.
Mhm.
The other thing that we have found is that for women who take hormone replacement therapy after menopause, they have at least the evidence is showing at this point that there may be a decreased risk in Alzheimer's. So you don't even have to do two different things. We're not asking you to do two different things to decrease one and decrease the other. So I want to just take a moment or two, Jane, before we get to questions, is that I really want to run through so people leave here today with knowing what are the things that you can do to
Mhm.
minimize your risk of heart disease.
And I think, Sharon, you hit on a really big one that we don't think about, our sleep. And it's not just duration of sleep, it's the quality of sleep that you are receiving. Constant interruptions of your sleep have a pathophysiologic process that lead to what? Inflammation. There's that word again. You have an inflammatory process that's triggered just by chronic interruptions of your sleep. That's why people with sleep apnea have an increased risk of heart disease. Not only do they have chronic interruptions, they have that low oxygen level. Think about weight and what we can do to decrease our weight and to make certain that we do not carry around a lot of weight for a long period of time. We are understanding now what it means, the toxicity of obesity. It's not being overweight, it's how long Have you carried that weight, the duration of time with that? And certainly there are all types of socioeconomic factors, including access to healthcare, who gets it. And quite frankly, even if you have healthcare, the type of insurance that you have in the United States, insurance is not all equal. So the type of insurance you have will dictate whether or not it's easy to see a specialist or not, how many specialty visits you get, whether you're on a generic medication, whether you have, so it's all different. It's not the same. And we need to make certain that you understand that. Certainly walking, exercise, all those things that are risk, smoking, making certain that you are addressing your cholesterol, asking for it to be checked, and then making certain that it is reduced. So, and blood pressure, we cannot forget blood pressure. We certainly don't have enough time to talk about blood pressure, but these are all things that you can begin to think about. Don't be overwhelmed with the whole list that I just gave you. Maybe pick one, just pick one and
Right.
just start there and begin to have these conversations with your doctor.
Right. And if we have to say this again and again and again, how important exercise is,
Mhm.
because I think, I used to hear this from my patients a lot. I'd say, you really need to exercise. And they'd go out and they exercise and they would say, Dr. Malone, I exercised and I didn't lose any weight. And I say to you, I don't care if you lose weight. I do, but
Mhm.
my point is that the benefits that you are getting from exercise, you are getting whether you lose a pound or not. And I think that all the studies have shown that exercise as a way to lose weight is a fool's errand. If that's all you're doing, you are not going to lose weight, because if you're like me, I exercise, but I
Mhm.
also have an extra something on the day that I exercise. Such that
Mhm.
when you think about it, my calorie expenditure may even go up, on that day, but I eat it back because I had something else, because I reward myself because I went to the gym.
Mhm.
But please, 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 losing weight is not the point of exercise. It is really to increase your cardiovascular fitness is what we're really talking about today.
Mhm.
And I want to get back to the issue of, of hormone replacement,
Mhm.
because I think that not enough doctors understand and have taken the time to really do a deep dive into the data. They're still talking about information about a study that was done 21 years ago, and it's just not true. I think for women who take hormone replacement therapy, provided you have none of the contraindications for taking it, there is overwhelming evidence that is pointing in the direction that it decreases your risk of cardiovascular disease, if nothing more than by decreasing all those things that we talked about as risk factors, the sleep disturbance, the type 2 diabetes, that visceral fat, you tend to put more of it on after menopause. If you minimize those things, maybe the bank shot is that, and decreasing inflammation as well, is decreasing your risk of cardiovascular disease. So literally, don't sleep on that. And I think that when you go to see your doctors, you have really got to, I don't think you ask, I think you really demand that, that they address your issues. And if they don't know, or if they're still telling you something from 20 years ago, then you should go to menopause.org and pull up the 2022 hormone replacement, so the guidelines for prescribing hormone replacement therapy, and addresses all of these things that we just talked about, particularly as it relates to cardiovascular disease, and give that to your doctor and say, hey, you might want to read this, because these are the reasons why it's important, not just because I'm concerned about vanity or anything else, but this really affects long-term health. I
You know,
want to take, before we run out, I want to say, we want to take a few questions. I know that some of you sent some in ahead of time. So I'm going to ask Kristen to join us and see if we have a few questions that we can answer for everyone today.
Yes, we do. Thank you, Dr. Sharon. I appreciate the intro there. We actually have a ton of questions that came in, whether it was social media, email, or in the Q&A feature that we have available. So for all those who did submit questions, we will try to get through as many as we can. If we're not able to get your question, we do apologize in advance, but feel free to check out Alloy's website. There's a host of educational tools on that website. So you never know, if you go on there, your question, there may be an answer on there for your questions specifically. So
Right.
Um,
And can I just say this too? And then we're going to provide a link to Dr. Morgan's Stairwell Chronicles, because she has, really concise, bite-sized sort of snippets for a lot of the things that we've talked about. And we'll share that link as well at the end.
Yes, absolutely. Okay, so for the first question here, someone submitted this and it says, I'm 57 and on HRT, specifically estrogen patch and progesterone IUD. And my doctor is asking how long would I like to be on it? So if we could just really talk about the timeline as a whole, when it comes to how long, what age are you supposed to start it? All of those type of things.
Yes. According to the 2022 guidelines, what we have, the data sort of says that for women who are menopausal and you are bothered by symptoms or you have these risk factors for things that we've talked about, as long as you start your hormone replacement regimen before age 60 or within 10 years of having had your last menstrual period. That's where the benefits clearly outweigh the risks. And it doesn't even, unless we will not talk about the outliers, because there's some instances where women can start later, but we're going to stick with the guidelines. Once you are taking hormone replacement therapy, you can take hormone replacement therapy for as long as you want to take hormone replacement therapy. And I think that when we're talking about the long-term implications, particularly of heart disease, and the thing we didn't touch on today was osteoporosis prevention, and hormone replacement therapy is the only thing that really preemptively prevents osteoporosis, then starting your hormone replacement therapy as soon as you are menopausal and you can continue it indefinitely. There is no arbitrary cutoff or the age at which you should stop. You stop because something in your health history really changes that would make you not a candidate. But as long as you're good and you're doing well, continue.
Amazing, amazing. Okay. Another one is, what are some safe non-hormonal medications?
What are safe non-hormonal? I mean, let me say this, and I will get back to this North American Menopause Guidelines. If you are symptomatic, and let's just say, and hot flash, we'll take hot flashes as an example. They agree, the American College of Obstetricians agrees, there is nothing that is more effective than hormone replacement or estrogen therapy for treating the symptoms of menopause, because there are other things that we didn't touch on today, such as the vaginal dryness, the irritation, the urinary symptoms that are also treated with hormones. And that, to be said, let's just be clear, a lot of the over-the-counter supplements, I will say there's no data on them. If they work for you, they work for you. But, and here's the big but, you're not going to get the long-term benefits that we talked about from hormone replacement. So to be safe, I would say, let me see, the things that are out there, and I'm not going to even go into them, but let's just say they're safe. I don't know if they're effective. How about that?
And to add to that is, which is one of the reasons that I'm here, is that do any of these other supplements give you health outcomes that reduce your risk of a heart attack or a cardiac event later? That's the whole point of drawing this line between menopause and heart disease, for you to understand that. And thus far, we only have data that estrogen, with these anti-inflammatory properties, has the ability to make certain that you can continue to reduce your risk of a cardiovascular event.
Right. And I'm going to make just one additional point on that, is that rather than do supplements, if you want to go a non-hormonal route, and this goes for everyone, but particularly if you're going to eliminate that as a possibility, or you cannot take hormones, diet. And that's the one thing that Dr. Morgan and I did not really get to, but you are far better off. Whatever it is you're trying to get in a supplement, you are better off getting it from your diet, because one of the other risk factors for cardiovascular disease is really highly processed foods. And you know what they are: chips, cookies, all the things that taste good, bacon, all of that. It is because these foods contain chemicals and added sugar, added salt, things that your body really does not know what to do with. And they make certain cardiovascular risk factors worse by taking them. So I would say if you want to spend your money on something, I would say spend your money on good, high quality, whole foods rather than trying to make up the difference and take supplements in a pill form.
Thank you both for that. All right, this next one is a two-part question. How do we push the needle on research? And also, how can I find out about a study to participate in?
All right, Jayne, do you have any cardiac studies that they can participate in? Uh-oh, Dr. Jayne is frozen. I'm going to tell you this. You can go online. You can go to NIH and see, I think there's a website called When We Trial, which actually will list studies and things that you can sign up for. But a lot of that is also to ask your doctor. Your doctor should, if they don't know, they personally don't participate in a trial, then they should be able to get you to someone who does. And we'll also provide some resources and places where you can go and sign up, because there are a few of them. And it also depends on where you live, because where, there are, if you live in rural areas or places that are not in, around major academic centers, it's harder to participate in a trial, to be sure, than if you live in a city where you have a major academic institution that you might be able to find.
Thank you, Dr. Sharon. We did lose Dr. Jayne, but she's going to try to rejoin here shortly. Okay. So let's keep it moving with the questions here. Let's see. So Dr. Sharon, earlier you talked a little bit about disturbed sleep. So this one is specific when it comes to sleeping habits. How would you define disturbed sleep? And is it a certain number of wake ups or the length of being awake once you are awake?
Yes, I'll give you a general guideline. You should aim for getting at least 7, believe it or not, 7 to 9 hours of sleep a night. Now, I don't know anybody who sleeps 9 hours of sleep, but if you could, that would be better. Most of us are not getting enough sleep because one thing we haven't talked about is really these devices that we have in our hands. We spend too much time on social media. We waste time doing things when you should be asleep. If you have your phone next to your bed, don't. Turn it off, put it on do not disturb, and try to develop a routine. And when I say that, there's what's called good sleep hygiene, where you give yourself at least half an hour, if not an hour, before you go to bed, just to decompress. You don't watch TV, don't look at disturbing images, don't tweet and do all the things that we do on our phone, because these things really affect our sleep. And again, look at things that may be causing you to wake up in the middle of the night, like hot flashes, because there are many people that the reason why they wake up is because they've got a hot flash in the middle of the night. And of course, you're in a sweat, then you've got to get up, change your clothes, all that, which is disturbed sleep. And another really important one is sleep apnea. So if you have been in bed and you think you've been asleep for 8 hours and you still wake up the next day and you're exhausted, I think that one of the things that you really should do is go and get a sleep study, because they can actually tell you, even when you are unaware of it, how many times you might be awakening in the middle of the night.
Absolutely. All right, Dr. Jayne, can you hear us?
I can. Can you hear me?
Absolutely.
All right, we'll keep going.
We're all set. Okay, Dr. Jayne, this question is actually for you. So I keep hearing about inflammation. What do I need to know about that regarding estrogen and heart disease?
So when we look at inflammatory factors, so there's something called the C-reactive protein and adipokines, all these kinds of things that are related to fat and our obesity and the amount of weight that we have and this visceral fat and something called metabolic syndrome that we haven't touched on today, but has to do with your high levels of cholesterol, your obesity, as well as your diabetes. One of the things we want to do is to try to mitigate or diminish or reduce the inflammatory processes in our body. And Sharon touched on that when we talk about the types of foods that we eat. Food is medicine. So one of the things to think about is, how are you going to move forward with your diet? Elimination of processed foods, which may or may not be easy for people. I mean, many people live in food deserts where a primary store may be the dollar store, where there are not fresh fruits and vegetables. But by and large, if you can reduce the amount of processed foods that you are eating, packaged foods, increase the amount of fresh fruits and vegetables, decrease the amount of red meat that you're eating and fried foods, all of those things trigger inflammation in our bodies as well. And then one of the reasons that Sharon and I are talking is that the whole menopausal process also is not a friend of inflammation. And so what do you need to do as you transition through menopause to make certain that you have the information that will continue to protect your heart as you age?
Right. And, I try to tell this because I have this conversation with my children, my young adult children who live on their own and now have control of their own diets. They give me the excuse, oh, Mom, I don't have time, and they're ordering, and it's Uber Eats and DoorDash with who knows what they're getting. And this is honest to God true. The amount of time that you wait for your DoorDash or your Uber Eats, you could have cooked. Because it's not even hard. We're not asking you to do, Chateaubriand. We're not asking you to do anything complicated. It is just go put a piece of salmon in the oven, make a salad, eat some, eat a whole grain, eat some, I mean, it literally takes 30 minutes. So I don't want people to use that excuse that, or I don't know how to cook or whatever. Everybody can cook. I said, if you can read, you can cook. And it's just a matter of organizing yourself such that, you're not having to answer this question on a daily basis. People can do meal prep, go to the grocery store once, but these are things that I want people to really, really know. Because it doesn't have to be hard. I think we make it hard. And not only that, not only will you be doing yourself a world of good, but you'll be saving yourself a lot of money too, because all that door dashing is expensive.
Mm-hmm.
Yeah, Dr. Malone, I learned the hard way with that one. Came to no more.
Right.
All right, this next question is related to breast cancer. So specifically, this individual submitted, my sister died of breast cancer. Is it safe for me to take hormone replacement therapy, MHT, menopausal hormone therapy, sorry. But any background history, can you just talk a little bit about that?
Sure. Now, this is a big one because it comes up all the time when we're talking about menopausal hormone therapy. We put that idea out there because that study, the Women's Health Initiative that was done 21 years ago, said that there was a 26% increase in the risk of breast cancer in women who took hormones. And that has stuck like glue. It is out there. So, oh, I can't take hormones because I have a family history, or my grandmother had that. That study has really been sort of, I'd say, overly generalized. The reality is, we get back to what I was saying before, for women who take hormones within that window, if you start them early at the time of whatever time you have your natural menopause, or sometimes you've had menopause because you've had surgery and your ovaries are out. Younger women should definitely take hormone replacement therapy. But what we have found for women who start within that window, within 10 years, or if you're younger than the age 60, there is no increase in your risk of breast cancer. The North American Menopause Society has affirmed this in their new guidelines, and they said even for women who have a family history of breast cancer, taking hormone replacement therapy does not increase whatever your baseline risk is. Now, that's not to say that you won't get breast cancer. You might, but whether you get it or not is not going to be dependent upon whether or not you took the hormone replacement therapy. And I think this is a data point that everyone should take into account. The overwhelming majority of women who get breast cancer are not on hormone replacement therapy. So breast cancer will be with us. It does not increase your risk. And here's another, and I don't know why this never got out there in the lay press, but in that same study, the Women's Health Initiative, the same study that said that there was a 26% increase in the risk of breast cancer. And let me tell you what a 26% increase really is. It's the addition of, it's fewer than 1 per 1,000 women per year they attribute the risk to breast cancer. Even if you believe that worst case scenario of that study, less than 1 per 1,000. The rate of breast cancer in women who don't use hormone therapy, and that's the combination of estrogen and progestin, is 30 per 10,000 women per year will get breast cancer. For women who took the estrogen, 38 per 10,000. And so that's where that number comes up. So the risk, even though it might be there, is small, even if we believe that, and that's contested. But here's the other part of that study. For women who took estrogen only, because with hormone replacement therapy, if you've had a uterus, you don't need to take estrogen and progestin. You can just take estrogen by itself, because the only reason the progestin is there is to protect the lining of the uterus. So no uterus, no progestin. That same study that said there's an increase, they found that for women who took estrogen only in that study, they had a 22% decrease in the risk of developing breast cancer. And more importantly, they had a 40% decrease in the risk of dying from breast cancer, even if you got diagnosed while you were on hormones. And I think that is a very significant point, particularly for African-American women, because we also have a disproportionate rate of getting hysterectomies. So there are all these women out there who have had hysterectomies where it's even a better idea for you, because not only are we going to be addressing the cardiovascular disease, osteoporosis, type 2 diabetes, but we may actually be improving the incidence of you getting breast cancer, making sure that it's lower, and if you get breast cancer, decreasing the risk of dying. So long way of saying a family history is not a reason to not take hormone replacement therapy. Even if you have a family history, even if for women who have the genetic variant, such as the BRCA1 and BRCA2, even those women, once they have had their surgery, either a mastectomy or have had their ovaries removed, they too can take hormone replacement.
Thank you for all of that, Dr. Malone. All right, this next question is for both of you all. How does micro and macroaggression intensify the symptoms of menopause? Can you all talk a little bit more about that?
So maybe I'll start and I'll just give the cardiovascular perspective. When we look at the United States of America, which is where all of us live, in all 50 states, Black people have a lower life expectancy. That's in every single state in the United States. So this is not just by happenstance. When you look at Black women, especially Black women who are navigating corporate America or in different types of positions, the chronic, unrelenting stress of microaggressions, macroaggressions, navigation of your environment, and the weathering that occurs. Weathering is a very specific term of wearing down over time. And this is especially true for Black women who are the mothers of Black sons. They self-report an even higher level of chronic stress. And we haven't talked about stress. Stress also increases the inflammatory process and increases not only the risk of cardiovascular disease, the actual numbers of heart attacks that we will see. So this is not innocuous microaggressions, macroaggressions that we experience on a daily basis within our culture. Again, this high tolerance for suffering and for injustice, as we talk about this today on Juneteenth. So absolutely, absolutely correlated with data and numbers to poor outcomes from a cardiovascular perspective.
You know, and I could not agree more. We are not built for chronic, human beings are not built for chronic stress. We're built for occasional stress because you need it. You know, you got to run and save your baby from a saber-toothed tiger or something like that. But on a daily, unrelenting basis, it affects your blood pressure. It affects your risk of getting cancer. It affects just about any disease process that we're talking about. Chronic stress is going to make that worse. Now, what are we going to do about it? You know, a lot of it is, well, you say, I can't always control the stressors in my life. But what you can do is not minimize it and know when you need to get help and figure out the things that you can do, be it exercise, be it prayer, yoga, talking to your friends. Do not internalize that stress because you are doing yourself no good by doing so.
Thank you both.
Okay.
Okay, I think we have time for one more question here. And while you all are answering, I'm going to drop some of those resources in the chat. So everyone feel free to take a look at those. Okay, so this last question here is, how do you know if you are, I don't think we covered this. How do you know if you are in perimenopause or menopause? How can you tell the difference?
Okay. Perimenopause is way harder to know where you are just than menopause, because menopause has a definitive end. You know you're in menopause when you've had no bleeding for a year, you're in menopause. Or you've had surgery, ovaries removed, you've had a hysterectomy and your ovaries removed, you're in menopause. Sometimes you can be in menopause from chemotherapy or radiation, where you go into menopause earlier than the normal age. But for perimenopause, it's kind of nebulous. But I think here's a good rule of thumb. If you are over the age of 40, you're probably in perimenopause, whether you're having any symptoms or not, because you don't have to have symptoms for these sort of hormonal changes to start happening in the background. So if you're over 40, you probably assume that you are. Some women, it's even earlier than that, but particularly if you start to experience symptoms, those same symptoms that we talk about, the hot flashes, mood swings, sometimes it's irregular bleeding. And that also will sometimes be the first sign that that women are in perimenopause. So it's not really a diagnosis that's made by a blood test or a sonogram or a physical exam. It is really based upon your age and or symptom profile. But again, you don't even have to have symptoms. We know that your periods are not going to last forever. They will stop. So just think about it. If you roll that back 10 years, you're in perimenopause during that entire transition time from your peak reproductive years, usually that happen in your 20s and 30s, until you get to menopause when you're 50s. And perimenopause can happen anywhere in between.
Mm-hmm. And think about that human beings are the only animal species that really live beyond our reproductive years. So we really have no animal models. And in fact, even in human beings, in Homo sapiens, which is what we are, this entity of longevity is only something that has really occurred in the last 100 years or so. We really didn't live pretty much beyond 35 to 42 years of age for centuries and centuries and centuries. And so as we have these questions and are moving forward, this is all in many ways relatively new. We saw at the Women's Health Initiative, there's a stumbling block. Now we need to reset. We need to understand what is the correlation with cardiovascular disease. How are we going to speak up so we can continue to push research forward? So this concept of longevity is very singularly human. because other animal species don't live really beyond their reproductive years.
Right. So I would like for everyone to think of not menopause as something to dread, but menopause is actually, that's the bonus. That's what you get for the privilege of living longer.
Mhm.
So, we're here to say that it is not something that you like, oh my God, it's dread and disease. It's not. I think it's safe to say Jayne and I are menopausal women. We can speak on this. And there's a lot of life to live, and how you choose to live that life, the quality of those years, which will encompass as much as a third of your life. You'll spend more time being menopausal if you're lucky than you did spend in your reproductive years. This is where we're trying to really have the most impact, not just on the length of your life, but the quality of your life.
Absolutely. All right. Thank you both, Dr. Morgan, Dr. Malone. We are at time here. So listeners, we did put information in the chat there for you to utilize those as resources. Definitely check out Dr. Morgan's Stairwell Chronicles series there. She has a bunch of education on her YouTube channel, amongst all of her other social media channels. Dr. Sharon also has a website that you all can check out just to learn a little bit more about her and what she does. And then Alloy, we have our website. It's www.myalloy.com. Check that out. And we are offering a coupon today as well for first-time customers. So it's $25 off. And if you use code Juneteenth, fully capitalized, you'll be able to get the $25 off. Dr. Jayne, Dr. Morgan, anything else you all want to, Dr. Jayne Morgan, and Dr. Sharon, is there anything else you all would like to add before we wrap up here?
Happy Juneteenth.
Happy Juneteenth. It was a pleasure.
Thank you all. Enjoy the rest of your day.
Okay, bye-bye.